In this video, after opening the anterior abdominal wall, we describe how to take a tour through the abdominal organs. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. The abdomen is packed with structures that enable us to digest and process food. In this video, we begin the dissection of the abdomen by examining those structures that are visible upon reflection of the anterior abdominal wall. Let's start the survey inspection of the superficial contents of the abdomen. Previously, we dissected the anterior abdominal wall and demonstrated the various layers of muscles and connective tissue layers that make up the anterior abdominal wall. In this dissection, the left half only of the anterior abdominal wall has been reflected and the content of the abdomen exposed. The space we have entered in this dissection is the peritoneal cavity, specifically the greater sac of the peritoneal cavity. We mention these terms here because as we proceed with the dissection of the abdomen, they will come up again, and because clinicians use them all the time. Hence, you need to be aware of these terms. The first organ we note is the liver, and a membrane is attaching the anterior surface of the liver to the posterior aspect of the anterior abdominal wall. This membrane is a falciform ligament and is a remnant of the embryological tissue in which the liver developed. At this point, we need to cut the falciform ligament from the posterior aspect of the anterior abdominal wall and finish reflecting the anterior abdominal wall as shown in the next slide. Upon reflection of the abdominal wall, the most dominant characteristic of the abdominal contents of most cadavers is the yellowish tinged material we call fat. It is everywhere, and this is beneficial because fat is a good insulator and also cushions the abdominal contents. However, of course, now obesity is all too common, and this results in an excessive amount of fat in the abdomen. Cleaning of this fat is very time consuming, and this cleaning has been an argument for the elimination of dissection. That is, the argument contends that students spend more time cleaning fat than identifying and learning anatomy. We are sympathetic to this argument, although we still believe in the didactic value of dissection for students who have the opportunity to do so. And to belabor this point, here's a cartoon of what most students assume the content of the peritoneal cavity will look like once they enter the cadaver. Our abdominal content is unlikely to ever resemble this stylistic view. Indeed, oftentimes, the large fatty tissue observed in the previous image is completely left out, and yet it is this fatty tissue that likely allowed mankind to survive on this earth prior to antibiotics. The most superficial structure of the abdomen is the greater omentum, a fat-embedded flap of tissue that covers the abdominal contents. It is known as the abdominal policeman because it tries to encapsulate any abdominal disease process in the living. In fact, part of the reason that the abdomen dissection is difficult to initiate is due to the likely adhesions of the greater omentum to the anterior abdominal wall and to the organs of the abdomen as a result of the omentum trying to fight off infection during the cadaver's lifetime. Once these adhesions form, they are further exacerbated by the embalming solution applied to the cadaver. In the upper right quadrant, we can identify the liver and the gallbladder, which is often stained green, as here, from the postmortem release of bile. Note also how green the liver appears. After dissecting this cadaver, we notice the hepatic duct was blocked and bile had accumulated in the liver, turning it pathologically green after embalming the cadaver. Usually, the liver in the cadaver appears a dark gray-brown. Just to the left of the liver, we can see the stomach, which varies significantly in shape and size. The greater omentum takes its origin from the greater curvature of the stomach. Overlying the liver and stomach is a muscular diaphragm, which separates the thorax from the abdomen. Here, we have raised the diaphragm to better visualize the liver. In the right quadrant, we can see the cecum and the beginning of the ascending colon. Loops of small intestine are also visible. Finally, in the left lower quadrant, the termination of the descending colon and the beginning of the sigmoid colon are visible. Before continuing with much deeper structures, the next step is to raise the liver as is being done in the image to identify structures in the upper quadrants. We again see the liver, stomach, and gallbladder, but now we can identify the continuation of the stomach, the duodenum. This is the first part of the duodenum and is considered all intraperitoneal. Also, clearly visible, is a membrane of the superior border of both the stomach and duodenum. Given that we previously identified the fatty membrane hanging from the inferior border of the stomach as a greater omentum, this membrane is known as the lesser omentum. Specifically, the greater omentum hangs from the greater curvature of the stomach, whereas the lesser omentum extends from the lesser curvature of the stomach and the duodenum to the liver. The lesser omentum is further subdivided into the hepatogastric ligament, the portion of the lesser omentum between stomach and liver. Gaster is another name for stomach, and hepa is Latin for liver, and the portion between the duodenum and liver is known as the hepatoduodenal ligament. And before you think I am trying to overwhelm you with an abundance of terminology, all these terms are of clinical relevance because of how the abdominal blood supply travels within all these membranes. In addition, the lesser omentum also represents the covering of the lesser sac. Remember, when we enter the peritoneal cavity initially, we enter the greater sac. Now we see the lesser sac resides posterior to the lesser omentum. Hence, the peritoneal cavity can be considered as two separate cavities within one. And where's the entrance to the lesser sac? Here it is. My index finger has been placed into the epiploic foramen or foramen of Winslow. Anterior to the finger is the hepatoduodenal ligament, and within this ligament you will dissect the bile duct, the hepatic artery proper, and the portal vein. More than one general surgeon has saved a life during their career by applying pressure to this membrane to stop the bleeding from a hepatic artery injured during surgery to remove a gallbladder, a procedure termed a cholecystectomy, likely due to gallbladder stones. When we study the blood supply of the abdomen, you will see how prominent the vessels are within the membrane. Moving to the left side of the abdomen, reflecting the stomach to the right and raising it some, we can now barely make out the spleen in the upper left quadrant. Students in lab often cannot find this structure without the help of the instructor because it is so deeply located and because it is also partially hidden by the lower ribs. In a separate video, we will get a much better look of this organ and also demonstrate its blood supply. But for now, we simply need to reach in, grab the organ, and bring it from behind the stomach, as was done to generate this image. In the image also, the descending colon makes its appearance, specifically the splenic flexure of the colon. It is here that the transverse colon becomes the descending colon. Importantly, this is a watershed area in the colon with respect to its blood supply and we will discuss this topic further in a different video. Note also that a ligament stretches from the splenic flexure to the diaphragm. This ligament is known as a phrenicocholic ligament and provides a small shelf for the spleen to sit on and not migrate inferiorly into the abdomen. As you can see in this image, the greater omentum can be reflected upwards to reveal the many loops of the small bowel. If adhesions are formed between the greater omentum and the small intestines, they have to be torn apart carefully in order to reflect the omentum. Most of the digestion occurs within the small bowel. If you look carefully, however, you can also discern the transverse colon of the large intestine. This particular cadaver is quite fatty, and the large intestine is masked by this fat. In some cadavers, the large intestine is readily visible. I now place some downward traction on the small bowel with my right hand to reveal more of the abdominal structures. The duodenum is the first part of the small bowel, and it's located against the posterior abdominal wall as it wraps around the pancreas, which is hidden from view here by the greater omentum. We can now also see the proximal loop to the second part of the small bowel, which comprise the jejunum, and the distal loops of the third part, which comprise the ileum. There's no specific point at which the jejunum becomes the ileum, but rather a gradual transition in features such as wall thickness, which is much greater in the jejunum than in the ileum. Also, it is apparent in this image that my left hand is pulling on the cecum, which is the first part of the large bowel, and we see the ileocecal junction, which is where the ileum empties into the cecum. Further reflection of the cecum reveals the appendix. This worm-like structure is not known to have any function, yet it is clinically relevant because the opening between the appendix and the cecum may become occluded, and this results in the appendix swelling and, if not treated, bursting. This condition is known as appendicitis. If such a condition occurred in the patient, then there would be evidence of the greater omentum having tried to encapsulate the ruptured appendix to prevent further spread of the infection in the cadaver. The small intestines have now been reflected superiorly to expose the posterior wall of the abdomen. The area from which the mesentery of the small intestine originates is called the root of the small bowel mesentery, and is a discrete area. It represents the origin of the mesentery of the small intestine from the posterior parietal peritoneum that is attached to the posterior abdominal wall. Posterior to this membrane, we will find retroperitoneal organs. Although the descending colon is visible in the image, it too is considered a retroperitoneal organ because it lies posterior to the parietal peritoneum. This now concludes this short video on an introduction to the contents of the abdomen.